All right, if you could start taking your seats, we're going to begin very shortly.
Okay, gonna get started. Hi. So hello to everybody who's here and hello to anybody who's watching at home. I'm Dr. Kourtney Santucci. I work here in Denver at the Children's Hospital, Colorado. And so I'm part of the hometown team, I guess. And it was Crystal who invited me to come and speak. And hopefully I'll share some useful information about basically what we're going to focus on here is the GI, kind of the intestinal manifestations of Wiedemann-Steiner. And what I want to convince you of, I think, is that even though we might not have a whole lot of published papers that are specific to the GI complications or management in Wiedemann-Steiner, that we can probably learn from other very similar and related conditions and can draw maybe from those experiences to help inform how we would care for our kids who do have Wiedemann-Steiner. I should not say kids. I'm a pediatrician, but I realize that some of you may have children or family members who are adults. So if I slip up at any point in this talk and say kids, it's only because that's the pediatrician in me. So please excuse me if I do. So my disclosures, I don't have any relevant financial disclosures. My only disclosure, I think, is to say that, gosh, I love being here in Denver, and I'm maybe unusually proud to be here in Colorado and working at the Children's Hospital of Colorado. Our clinic where I work is a medical home and consultative practice available only to children who have medical complexity. So while I am a general pediatrician, I only take care of kids who have kind of a lot going on. And that is the same for my 17 colleagues who I work with as partners. We have about 3,000 patients that we're taking care of who have a variety of genetic and metabolic conditions. We will say, oh, I should have mentioned this at the beginning. We will have a question and answer session time at the end of the slides, where we will try to get through all of the slides in continuity first for purposes of the recording. Okay. So as an overview to what I'll talk, hello. As an overview to what I'll talk about here, first we're going to review what literature there is on the GI manifestations of Wiedemann-Steiner. And then we'll review what's known about kind of what can we glean from those conditions that are somewhat similar to Wiedemann-Steiner in terms of GI complications. And I'll do my best to suggest some practical strategies for managing GI symptoms. Okay. So first, just to say, like, what are the big GI complications? What kind of GI stuff are we thinking about for Wiedemann-Steiner? Pretty much boils down to, I would say, three big things. One has to do with the hypotonia that is so universal, I would say, and pervasive across the diagnosis. Hypotonia relates to and kind of can contribute to issues, especially in the very young months and young years, issues with feeding and swallowing difficulties. So many times we know that this will kind of show itself in infancy, and our youngest babies may, for a time, need nasal tube feedings, or if the swallowing's not getting better kind of quickly, doctors may recommend a surgical tube to be placed. But I would say the silver lining maybe is that in Wiedemann-Steiner, in general, things get better, right? The oral motor coordination improves and the swallowing can get better, so that even if there is need for a feeding tube early in life, it's usually not something that needs to stick around necessarily forever. And biggie here, it seems to be fairly common, is constipation. So we'll talk a fair bit about one of my favorite topics, constipation. So here's from the published literature. One of the resources or sources that doctors like me who deal in medically complex conditions or rare conditions love to refer to is an online resource. It's put out by the National Institutes for Health, or the NIH. It's called Gene Reviews. It's sort of just like the encyclopedia for rare genetic conditions, and it can tell you a whole lot in a little bit of time about any given condition. And so there is a Gene Reviews entry for Wiedemann-Steiner, in which the quote up there at the top says, Wiedemann-Steiner syndrome should be suspected in individuals for the following clinical, imaging, and family history findings. And I just wanted to point out that in that, like, who should we even be thinking about? There are really 3 GI things right there on the list of what's common in WSS. So distinctive facial features, you guys are all very familiar with. Hypertrichosis, the same. Sacral dimples. I think you're all very familiar with the developmental delays that may be apparent in Wiedemann-Steiner. Hypotonia, feeding difficulties, failure to thrive, which basically is a term that means when a child is not following their growth curves. So if we're taking care of an infant or a young child, every time they go to the pediatrician's office, a weight and a length are measured. And we expect that children will kind of pick a curve and stick with it. So even if a child does have short stature, we expect that short stature would continue to progress and grow over time. But even if we start out at the 1st or 2nd percentile for height, we want to maintain that. Failure to thrive is a child who may start out at, say, maybe 50th percentile for weight, but as time goes by, the weight percentile may go lower and lower and lower, indicating the baby's not getting in enough calories to keep up with their length gains. And then the short stature and the constipation. Okay, and then so how prevalent are these things? Again, from Gene Reviews, and this is only put out just 2 years ago, so pretty fresh data. They cited the incidence of constipation in Wiedemann-Steiner patients, and this is just based on symptom report from families, from the patient themselves, as half, so 50% reported constipation. 64% experienced failure to thrive, so not following that growth curve like we would expect. 62% having feeding difficulties. Again, generally only in infancy and young childhood, so generally something that did get better as the lifespan went on. Incidences, though, if you want to look at this resource later online, for really all of the major symptoms are listed here. I realize it's probably pretty small to read, but openly available online. There's also in the literature, I thought, a really nice, what we call a meta-analysis. So a meta-analysis is a paper that generally will present data that's been presented by others separately, but they'll compile it. And so it's a meta-analysis, a nice paper to look at if you want them to do the work for you of reviewing the literature, right? So these authors who were in China, they published in 2022. They shared about a singular child, a 5-year-old boy in China who had Wiedemann-Steiner, but they took the time to review all of the then published individual case reports and tell us what we could expect. And so in this compilation of just over 100 individuals worldwide with Wiedemann-Steiner, there the incidence of constipation was a little bit higher than in the Gene Reviews. So here we're at 63%, and similar number, 66% here experiencing feeding difficulties, about a quarter of whom, so about a quarter of the total patients of those 104 required a feeding tube. Typically, this was needed either due to oral aversion to food, so just the child not accepting food being put to their mouth, or severe gastroesophageal reflux. So sometimes children's reflux is just so bad they can't keep anything down, and we may have to use a feeding tube to feed beyond the stomach for a time. And finally, swallowing difficulties, or dysphagia, as we'll call it, was also a reason for some of these children needing feeding tubes. Basically, what we can expect is that, again, as the gross motor skills develop, the feeding disorders may improve due to the impact, basically, of the hypotonia, just getting better, getting to be less. So now just to turn our attention for a moment to, okay, so that I've kind of just reviewed for you all the WSS specific GI literature. There's not much. It fit into like, what, 5 minutes and two, 3 slides. But really, we could maybe think, well, what else? What are common and more common, I should say, and somewhat related conditions? So here's where, in my mind, I think to Coffin-Cyrus syndrome patients or Kabuki syndrome patients, Cornelia de Lange patients, all of whom you could put those cardinal features of hypotonia, developmental delay, high risk of swallowing difficulties, dysphagia. That's common amongst all of those, and the etiology is somewhat similar as well. And so why can we expect GI problems in a child who has low muscle tone? Like, why do those things go together? It has to do with the fact that central hypotonia impacts not just on our volitional muscles, kind of the muscles that we control by will, but also on our involuntary muscles, the ones that control our GI's movements. So when you swallow food, you don't have to tell your esophagus to go ahead and move that food down to your stomach. You don't tell your colon when it needs to move or not, right? Except maybe at the very end. But you know what I mean? So there's our involuntary muscles, but there are also muscles that are impacted by central hypotonia. And so when we think about, say, the gastroesophageal reflux, for example, we think about a muscle that's right there, pointer right there at the end of the esophagus, right where it meets up with the stomach. There's a little muscle. It's called the lower esophageal sphincter. A sphincter muscle is a muscle that kind of moves like the iris of a camera, right? It can open up and get wider to let food pass through, but it can also close down to keep food from coming back up into the esophagus after it's been swallowed down into the stomach. And when that muscle is hypotonic, so it doesn't have a particularly strong close to it, or if it's just kind of incoordinated. So if its closure isn't well timed to the esophagus having let something through and the stomach being rather full, then we can have contents that, you know, the child has swallowed down that then kind of slosh right back up into the esophagus. If we still have a little baby who's spending a lot of their day lying down, we can see a lot of spit ups, you know, so milk that just kind of comes right back up the esophagus and out the mouth again. And that's not good for gaining weight, right? And so the strategies that we can employ to manage that situation kind of boil down to ones that are similar to babies who have like acid reflux. So using antacid medications, positioning young children, so still infants generally, in an upright position after they're fed, so that maybe we can use gravity to our advantage so that milk doesn't just slosh right back up. Yeah. The other things, though, that are impacted by this central hypotonia are, like I was mentioning, kind of the movements of all of the intestines. And this contributes to kind of a lot of stuff. It can contribute to bloating, ineffective coordination of the abdominal musculature when it comes time to stool or to pass the poop. This is why our Wiedemann-Steiner patients are not alone in struggling with constipation, right? Really, having now cared for thousands of children who have hypotonia, central hypotonia, I would say I expect constipation in all of my patients who may have cerebral palsy, any number of other neurogenetic conditions that cause central hypotonia. So we're going to get into a little bit more now, kind of that practical, what do we do about it, and what should families know? What kind of evaluations or treatments should you be seeking? When it comes to the feeding problems, and I'll go through the GI symptoms now a little bit, kind of top to bottom, starting with the top with feeding in the first place. Remember that coordinating swallowing is a really complex task. One thing that's interesting is that sometimes when babies are first going home from the hospital, they may be thought to be just fine when it comes to feeding and swallowing. And many of you may have experienced this. In the first couple of months after birth, feeding is rather reflexive, meaning the baby is just sort of wired at the level of the brainstem to be able to suckle and to swallow. And the awareness of any milk that may be going down not going down the right pipe, so anything that may be being aspirated, is rather poor compared to what it will be as this baby matures. So an interesting thing that can happen in children who have hypotonia is that once those reflexive feeders turn into a little bit more mature feeders, that's when at a couple months of age, we can actually start to recognize that there are problems with coordinating suck and swallow and breathe, and start to have outward symptoms of aspiration, which may be the baby pulling away from the bottle or from the nipple during feedings, getting like choked up or coughing during feedings, or just sounding different with their vocal quality after they feed because they've aspirated some contents and it's basically bothered the larynx or the voice box. If those symptoms, if those signs are present, hopefully parents would recognize that something's not going well and they would bring that up to their pediatrician or their healthcare provider. And hopefully that provider would say, oh, we might have dysphagia here. So we might have a problem coordinating swallowing. And the right study to do is going to be a formal evaluation of studying in one of two ways. So one study is called a modified barium swallow. This is where we basically take a little bit of barium to tint the milk that the baby will drink so that it shows up on an X-ray. And we will then feed the baby while they're in an X-ray suite with a moving picture X-ray being taken, and we'll watch where the milk goes. We hope that all of the milk, once swallowed, goes down the esophagus and into the stomach. We hope that none of it pools in the back of the throat or goes down the trachea, having been aspirated. The other way to do this, though, is the other way that this can be named is a VFSS, or video fluoroscopic swallowing study. What can we do about it if the poor swallowing or dysphagia is present? Well, therapy, right? So we want to first make the swallowing safer. If the baby can take a certain consistency of milk, that does go well. Usually this is also examined during the same swallowing study, but if we can kind of thicken up the milk to the point that it all does go down the right pipe, then we can feed the baby only that consistency or thicker. We'll also offer occupational and speech therapies to work on stimulating better oral awareness and oral motor coordination, so that things do get better over time. Sometimes, though, even with all the best that we can do with thickening milk and, slowing the pace of the nipple and maybe, pacing the baby's feeding so they can't kind of take too much at one time. Sometimes with even all of that being done, the baby's still aspirating. And this is a situation where maybe a nasal gastric or a gastrostomy tube might be needed for some time. I wanted to show this just because it's important to any discussion of dysphagia. This is the nomenclature, basically the International Dysphagia Diet Standardization initiative from 2019. We call it IDSI for short. But this was a group of people, swallowing experts, basically, who came together and said, this is how we shall name the different levels of thickness of things that people can eat and drink. And just to walk you through it a little bit, the right triangle has things that you would drink, and the left triangle has foods that you would eat. You can kind of see in terms of thickness, there's a little bit of overlap there. So if we work from the bottom right triangle on up, we're basically moving from things that are thinner all the way up to things that are thicker. So an IDSI level 0 is this. It's thin like water. So it's a truly watery, room temperature watery consistency. Slightly thick, formerly known as nectar thick in the old nomenclature. That's sort of like a very, very thin syrup. So think about syrup that you've thrown in the microwave for 20 seconds. It's super runny, but there's still a little bit of cloyingness to it, right? It'll still kind of cling onto a spoon. That's kind of the thinnest that we can thicken something up to. And many babies actually do fine with even just that little bit of extra thickness into their bottle. As we go up, there is mildly thick, moderately thick, which is sort of the same as a thin soup, right, that you would eat from a spoon. And then we've got extremely thick liquids. I always think about like a McDonald's milkshake that's really cold, super hard to pull through a straw. Actually kind of hard for a lot of babies to coordinate pulling something that's that thick. But that's similar to, say, pureed vegetables that you might have at Thanksgiving, right? So there's those two categories kind of give a place where drinks and foods kind of overlap, right? As we get thicker, we've got minced, moist meats and other foods. I would think about sloppy Joe meat there. And then soft and bite-sized foods, and then easy to chew foods, and finally regular foods. So if anybody ever hears or tosses around this term IDSI to you, this is what they're referring to. It's just a formal way to basically measure how thick stuff is. Okay. I wanted to spend just a moment on oral aversion, because that is sometimes the only reason why a child may not be successfully fed by mouth. So if their coordination of swallowing is good, but if the child just really does not enjoy certain textures or tastes or temperatures being put to their mouth, this can really give a problem with getting in enough energy if a child's just very picky. And so what can we do for this? We can work on it, right? We can do therapy for this. Pediatric feeding therapists are best that we've got. And these are people who are specially trained to work with children who have oral aversions to try to get them past that and able to take a more complete range of foods. Okay, a little bit more about that reflux disease. When we were, just think back to that diagram I showed a minute ago of the esophagus, think about the lower esophageal sphincter muscle. So very commonly when we have infantile hypotonia, we see this going along with GERD or gastroesophageal reflux disease. Again, this is due to hypotonia of those involuntary muscles like the lower esophageal sphincter. Antacid medicines can help to protect the esophagus from that acid exposure, which over the long haul can cause some changes on a cellular level to the esophagus, which aren't nice. And really, if there's going to need to be long-term use of antacid medicines, it's wise to bring in a pediatric gastroenterologist to supervise that. So that we can basically make sure that we're on the lowest effective dose possible to manage the symptoms, and weaning off of those medicines as soon as it's feasible to maintain the child growing. They're like all medicines, there are just some side effects in the long run we don't want to have to deal with if it's not truly, truly necessary for the child to have those medicines. Okay, my favorite, now we're there. And I apologize in advance if I ruin soft serve ice cream for anybody after this, but the reason I'm showing soft serve ice cream on the screen there is that, to me, that's the perfect poop. Kind of looks like the poop emoji, right? Like frosting consistency. And I just want to bring that up because a lot of times when I'm in a clinic visit and talking with families about their child's elimination patterns, I'll say, any struggles with constipation? And they'll go, no. And I go, tell me more about that though. Like, give me some descriptors. And they might say, well, it's usually, like it might be pretty hard, but they get it out. Or, there might be for some little balls first, like Play-Doh, but then, then a big poop comes. And I go, let's work on that. Because to me, I'm worried about the long-term game, right? Like I'm worried about the long-term tissue health. I'm worried about preventing some of the complications of long-standing constipation, like hemorrhoids, right? We can do better than rabbit poop, right? So we need to aim for soft serve ice cream. Constipation is really just so treatable, right? We have a lot in the arsenal when it comes to how can we help constipation be better. And so I think it's just worth focusing on and thinking about and, investigating to the extent that you can. Again, constipation, super common, not just in Wiedemann-Steiner, but all kids really who have low core, like central core tone, are at risk for this. When kids get backed up, usually they tend not to eat as well. And I think they get grouchier, right? So a constipated kid is usually a grouchy kid. And so I think we can really help other things besides the colon if we help the constipation. Maybe we can help appetite. Maybe we can help mood and behaviors. We have to remember that once stools get large and hard and painful to pass, kids don't like to poop, right? And so they will then withhold the stools longer. It's a nice sort of repeating cycle diagram that one of my good friends, Allison Blackmer, who published a paper just a few years ago on management of constipation in kids with medical complexity. This is a graph I totally stole from Allison's paper. She works with us here in Denver. But basically, you can start at the top with a child who's experienced passing a very hard and painful stool. because of that, they are now fearful and anxious to poop the next time. And so the stool is retained in the colon. The job of our colon, kind of physiologically, is to resorb water. The colon is an excellent sponge for water. The longer stool sits in the colon, the more the colon will do its job and withdraw water from that stool. And so if a stool sits in a colon for less than a day, it generally comes out pretty soft. If it sits in there for 3 or 5 or 10 days, it generally comes out very, very hard. And so that's where this cycle gets to be a problem, right? So we get our increased water absorption. Again, once that stool does pass, it's very hard, creating more fearfulness, more anxiety, and then we're stuck in a loop. So what can we do about it? I like to talk about the 3 Fs. This is just my little nomenclature here, but we can talk about fluid, we can talk about fiber, and we can talk about foods even before we talk about medicines, right? So let's talk about the basics first, and then we'll get to the medicines, because most of the time medicines do have to be a part of the discussion. Fluid. So in order for the body to stay happy, right, the colon does have to be able to resorb enough water so that you can maintain your circulation, right? This is extra important if it's a time of the year where the child is sweating more, or if you live in a very dry, high arid climate like Denver, where where it's just, you need more water in order to do well. This is your PSA to drink lots of water while you're here in Denver. But basically for scale, for a rough like guesstimate, so an adult sized person needs about 2 liters of water in a day. It's quite a lot. The smaller the person, the less is okay. But I usually think about like my kids just entering school, like young elementary age, about 1 liter a day. So I usually coach parents to send their kiddo off to school with a water bottle that they have filled up and expect that that bottle will be all empty by the time they put their kiddo to bed at night. And that's the way you can track it, right? Like if the kiddo has a preferred bottle, just kind of keep track of that. Like, are they getting enough water as much as they should? That'll be the first thing you can do to help constipation. Second thing that's just part of diet is fiber. So dietary fiber does not cross out of your intestine and go into your bloodstream after you eat it. Dietary fiber comes to us from, fruits and vegetables and grains. It's too large of a molecule to be absorbed into your bloodstream, and so it just stays in there with your poop. And it's very good at holding on to fluid and adding also some bulk to the poop to make it kind of keep passing along through the intestines. We know that fiber is also good for keeping cholesterol in good balance and healthy. So I'm a pediatrician. I talk to a lot of kiddos who like foods that kids like, right? Foods that are on the kids menu. This might be French fries, macaroni and cheese, chicken nuggets with like a breading kind of a topping, spaghetti. Pretty much none of that has fiber in it. And this is our natural challenge, I think, with children, is to coach them to find sneaky ways or any ways you can to get that fiber into them. Think about your blender, right? So blending up fruits and or vegetables into smoothies. If your child likes smoothies, can be a great way to get in dietary fiber without the child thinking that they have to eat salad. But basically aiming for dietary fiber to be in there. Worst case scenario, you can always add Metamucil or psyllium husk. These are things that mix in pretty nicely to oatmeal, to yogurt, or to orange juice, just to get enough fiber in the diet. For an adult-sized person, we're aiming for like 20-ish grams of fiber in a day. Again, half that size, about half that amount. Foods. Okay, so examples of constipating foods, like I was just mentioning, are everything on the kids' meal. So meats, breads, pastas, potatoes, fried and greasy foods, corn, foods that have high sugar level, sugar content. Generally, those don't make constipation better. And dairy, sorry. So I forgot about cheese and milk and some of these, all the good things, all the things that the toddlers just love, right? And this is probably why we tend to see, like, as children get out of infancy and start eating more regular foods, less baby foods, less formula and things like that, that's when the constipation becomes really a problem. It's all the diet. So as we think about our fruits and our vegetables, our beans and our whole grains, just thinking, I got to get this in there because that's where the fiber is going to be, and that's going to keep the poops moving. Okay, and now to talk a bit about the medicines. There are kind of, I would say, 3 big categories of medicines that help with constipation, and I group them into like 3 S's. So the softeners, the squeezers and the sliders. So softeners are osmotic laxatives. They will just keep fluid in the poop. They'll keep the colon from resorbing that water so that the stools stay softer. Squeezers or stimulant laxatives stimulate the colon to move. It's sort of like stepping on the gas pedal as hard as we can of a system that on its own just doesn't like to move very well. And then finally, sliders. So these are our lubricants, things like mineral oil or docusate, Correctol, as it's also known. So you can see some examples in each of those categories. Probably most people have heard about Miralax as a softener. Probably most people have heard about X-Lax as a squeezer. Those are, I would say, are two, kind of go-tos right out of the gate for most kids who are not able, who we can't manage their constipation with just fluid and fiber and foods. Okay. When do you need a specialist's help if your kiddo is struggling with constipation? So, so in general, we'll back up a little bit. We need a specialist if there are those signs and symptoms of swallowing dysfunction, right? That's not something I would say that pediatricians tend to manage on their own. We usually need a special study for that with the swallowing study. And we're going to probably need ENT and GI follow-up. For failure to thrive, a pediatric dietitian and a pediatric GI doctor can really help to make sure the child is thriving to the best that they can. We may need a pediatric surgeon if there is need for a long-term feeding tube. And then with constipation, I would say if we've tried everything that I just showed on the last couple of slides, and we're still having long-standing constipation or developing any of the sequela of long-standing constipation, like hemorrhoids or even rectal prolapse, then we need a specialist for sure. And I would start with a pediatric gastroenterologist. Okay, these are the references. I can leave this up there maybe for a second if anybody wants to just like take a photo of the references slide, because I'd say there isn't a whole lot right in the realm of WSS that's GI specific, but please go for what there is.